is Andrea from HIT 340 Comparative Records. We are now on week 11 and we are covering chapters 12 and 13 this week. This lecture video is on chapter 12, Home Health Care. If you are looking at your handy dandy syllabus, you will see this week we are focusing on unit objectives 9.6.1 through 9.6.8 and 9.7.1 through 9.7.7, and this home health is on 9.6.1 through 9.6.8. So let's talk about home health care. And what do we need to know? Well, the learning objectives from the book are to explain the basic operations of a home health care agency, identify future trends of the industry, discuss the importance of data collection, analysis, and reporting, and identify the types of services provided by home health care agencies. Home health care is an interesting type of health care. And so as we go through here, you'll find that when it comes to a setting, it's not like it has a single facility. It's an organization, and they provide services in the home environment. So it's a little bit different when we think about it. We'll also talk about the growth of home health care. We'll list the agencies, organizations that develop standards for home health care. We'll talk about OASIS. Okay, so we've talked about the MDS for the skilled world, and now we're talking about OASIS. So anytime you hear OASIS, you want to think home health, home health, home health. And then they have outcomes-based quality improvement and quality management that are governing home health care. So what is home health care anyway? Well, this is the definition you need to know. It's a service to the recovering disabled or chronically ill person providing for treatment and or effective functioning in the home environment, known as home care, visiting nurse association, visiting staff, all of that. The growth in home health care is related to cost savings, changes in reimbursement, technology, and advances in patient rights. As you think back, we will have talked about this in other classes, but prospective payment systems. What they did was they tried to push hospitals to be more effective first. And when they did that, patients were being discharged much more quickly than they used to be. If you go back, oh goodness, and I'm going to age myself here right now, but if you go back 30 years or so, or 40 years, 30 or 40 years ago, there was very little home health care. And the home health care that there was typically provided by a family member. Most of the time, patients stayed in the hospital until they were able to fully care for themselves at home. But then the DRG system came along, and that really challenged hospitals to be more efficient. And when that happened, they started sending patients home earlier and earlier and earlier. And that's where home health care came into being, is that there was a need for patients to receive this care in their home. Also, many patients did not want to go to a nursing home for some of the care that they needed. And home health gave them that independence. It gave them that ability to get some of the rehab services and nursing care services that they might have had to go to in a nursing home back in the day, now that they can get at home. So that's where it talks about that. It is far less expensive to provide services on a home health care basis than it is to be in a facility. And you can see that right off the bat. In the home, you're not paying for electricity, you're not paying for a building, you're not paying for around-the-clock care, those types of things. What you're doing is you're paying for the specific services you need to come on the days that you need them, or at the time that you need them, at the skill level that you need them. So that kind of covers all of that background. If you have your textbook cracked open, this chapter starts on page 446, and I have been chattering through page 447. So what are some types of home healthcare patients? You have the homebound. These are people who are confined to the home except for infrequent or relatively short absences that require considerable and taxing effort. A homebound status is required to qualify for Medicare coverage of home health care services. Patients are referred from a variety of sources, and physician orders are required. Note that for documentation purposes, physician orders are required to provide home health care services. We are now on page 448, in case you were wondering about that. So what are the types of caregivers that are involved in home health care? Well, you have skilled nursing. You have RNs who go out to the home and they do medical surgical type nursing. They handle IV therapies. They do enterostomal therapy. They may provide maternity, restorative, psychiatric, that kind of thing. Then there are also home health aides, and these are CNAs that come out to help with activities of daily living, taking vital signs, and then other activities as permitted by state regulations, because you got to remember, the states are the ones that determine what is in the licensure and how all that works. So in states that permit it, home health aides may do more than vital signs and activities of daily living. You may have physical therapists, occupational therapists, speech language pathologists. Those all come in and provide services as needed, as ordered, as justified by diagnosis. You have medical social services, sometimes nutrition or a dietitian. Respiratory therapists sometimes make home visits. And then there are other possible services that can be provided, like patient transportation, respite care, DME, Meals on Wheels. So those are additional things that might possibly be covered. Might, not guaranteed. And often not, I will be honest and say. So we are now up to page 451 in your book, regulatory issues. So what are regulatory issues as it comes to the setting of home health? Well, you do have Medicare, Medicaid conditions of participations, those good old COPs. You have state licensing agencies, because remember, each state does it differently. So their licensing agency is the one that is monitoring the home healthcare organization. They can have deemed status through Joint Commission, Community Health Accreditation Program, or Accreditation Commission for Healthcare. Sorry, I can't spit that one out. All right, I have been involved with home health care, and I have been involved with Joint Commission accreditation surveys of home health cares and preparing for those. So just so you know, I've been there, done that, lived that, and that is absolutely the case. Joint Commission will go out, and they will they'll send a surveyor, and the surveyor will actually, they'll come to the main office, they'll meet with some of the staff and leadership, but then what they really want to do is tag along with a home health care nurse as she goes out to care for patients. And they will actually tag along on some of those visits. All right, documentation. So if you are wondering where we are at now, we have skipped already to page 454, documentation. What does home health need to document? Well, they have to have certification, they have to have that physician's order, and they have to have a plan of care. There's no specific form that is required anymore, but the elements are. You have to have the elements. And we'll talk about OASIS here in just a little bit, but in order to start with home health, you have to have a face-to-face encounter with the patient to evaluate the patient and make sure that the patient needs these services. That usually happens at the physician's office or in the hospital right as the patient is getting ready to be discharged. So you have the doctor or the nurse practitioner or the PA or even a certified nurse midwife. They're meeting with the patient. They're having that face-to-face encounter to identify, oh, this patient's going to need home health services. So then they work with utilization management or social work, and they get that set up with a patient. The patient is the one who has to choose the agency. Hospitals cannot recommend agencies. Even if they own a home health care agency, they cannot recommend it. They have to give the patient a list of agencies in the area that provide services to Medicare, Medicaid, or other insurance patients. And then the patient chooses, and then they contact that agency. And the same thing is with skilled nursing facilities as well. But anyway, you have to have that encounter. Then you have to have the order for the care. And the order has to be clear about what care they need, and it has to be justified. You know, that there has to be some basis for it in the medical record for requesting the home health. Then a comprehensive assessment must be completed on the first visit. A care plan has to be developed that includes goals, objectives, and who is responsible for completing the plan. And I talked about physician orders. Excuse me. And then the services have to be provided by a registered nurse. There needs to be supervisory visits if you have a home health aide providing services. That RN has to follow up and make sure that the home health aide is doing what needs to be done. Or if a PT assistant or an OT assistant are providing the services, the PT or OT has to go in and do a supervisory visit just to make sure everything's staying on track, that nothing's been missed, and to really evaluate the progress that the patient is making with whatever therapy is being done. You have to maintain a patient database. You have to have hospital discharge information, referral information, patient bill of rights. Patients need to be informed of their rights, and they have to sign off on that. Advanced directives. If the patient has advanced directives, you've got to keep and maintain those. Do not resuscitate orders. If the patient has a DNR order that's been signed by their physician, that needs to be a part of the home health care record. Medication profile, progress notes, problem list, teaching guides, and discharge summary. Those are just the basics that are absolutely required. And so let's see, on to record format. It can be source-oriented, it can be problem-oriented, or it can be integrated. It really depends. Many home health agencies that are owned by healthcare organizations are on EHRs, just so you know. Many that are independent may still be on paper, which is why they talk about source-oriented versus problem-oriented versus integrated. Okay, so what is OASIS? It is a group of data elements designed to establish a means of systemic measurement of patient home health care outcomes. Outcomes measure changes in patients' health status between 2 or more time points. So what they're really trying to do with OASIS is they're trying to say, okay, here's the patient and their condition and all of their issues and all of the care that they're receiving. And now we're going to measure it. We're going to see if that care plan worked. We're going to see if the patient made improvements and strides forward. And we're going to measure that, their status, between 2 or more time points. Because at the very least, we want them to be the same. We don't want them to worsen. And ideally, we want them to improve. And that's what all this is for. The data is used in quality monitoring for not only the home health agency, but for Medicare in their prospective payment system. And then the data is submitted to the state agency through Haven software. Through Purchase software or Haven software. Most places use Haven software from CMS, but there are some that have Purchase software. But the OASIS data has to be transmitted electronically. Notice that. Even if it's paper-based records, the OASIS information has to be submitted electronically to CMS, whether you go through Purchase software or use Haven to put it directly in. In Medicare's home health prospective payment system, payment is for a 60-day period based on the patient's home health resource group, HHRG. And we're studying this week in HIT 3, hang on, 292. 292. So we're studying that this week. So this is kind of funny that they dovetail at the same time. But anyway, the prospective payment system, HHPPS, they use their form of DRG is called HHRG, and it's for a 60-day period. Medicaid uses a rate determined by the state. Private insurance typically looks at percentage of charges, but I would not be shocked if that changes eventually. And then self-pay is where the patient has to pay out of pocket. It means that nobody else is going to be paying for it but the patient. So these are the types of reimbursement you might run into with home health. With Medicare's home health prospective payment system, the payment is based on the OASIS assessment for that 60-day episode of care. The amount will vary based on the severity of the patient's illness as determined by that HHRG. And that HHRG is determined by answering certain OASIS questions. So OASIS is not just for quality improvement, not just for payment, not just for research, not just for identifying is the patient improving. It's got all of these components to it. That's why it's so important. The HHRG is based on 3 dimensions: clinical, functional, and service utilization. So make sure that you know this. This is important, really important. The HHRG is based on clinical, functional, and service utilization. And in case you're wondering where I'm at in your book right now, we started here with, when we were talking about OASIS, on page 457, bottom of 457, and that continues right on through to page 461, and talking about the clinical dimension and the functional dimension and service utilization. Those are defined here in the middle of page 460. So make sure you understand that these are what the HHRG is based on and what each of these is. What do they mean? Because you will need that. Hint, hint, hint. All right, so again, they're represented by HIPPS codes on claims, and these codes are 5-position alphanumeric codes that represent specific patient characteristics on which Medicare payment determinations are made. I don't think I will make you use that for a quiz question, but please be aware of it. You need to know the information on this slide. So just make sure you do. What's a LUPA? A LUPA is a low utilization payment adjustment. This happens when the episode of care is 4 or less visits. And so if a home health episode of care is 4 visits or less, it is not going to be the payment's not going to be determined by the HHRGs. It's instead falling into this LUPA, or this low utilization payment adjustment, and that's how it's dealt with. You can also end up with a partial episode payment, which is another type of adjustment. I don't know why they don't call it PEPA instead of PEP, but anyway, it's a reduced payment. It's based on the number of service days less than 60 in cases of transfer. So let's say that the patient somehow is transferred. Not sure what that situation would look like, but on the off chance that it happens and the patient changes healthcare agencies, I guess that's really the only thing I can think of, is that patient starts out with home health agency A and is very dissatisfied and decides to change to healthcare agency B. Or let's say you have a patient who is living in one city and receiving home health from agency A, and they end up moving closer to one of their children or grandchildren, and they'll be receiving home health agency B services. And so within that 60-day time frame, you have 2 different services. When that happens, or 2 different agencies, when that happens, you fall into the PEPA issue here, the partial episode payment adjustment. And your book talks about that on page 461. So I would go back to your book for that. All right, outliers. This is when patient has unusually high costs to the home health agency. And so adjustments have to be made for that. And again, that talks about, your book talks about that on page 461. And then a change in code assigned changes the payment when upcoding or downcoding happens. That can adjust it as well. Other financial issues you might run into is payer mix. That's a term describing the ratio of various types of third-party payers that provide revenue to a home health care agency. So, for instance, an agency can have 70% of its patients insured by Medicare, 20% by Medicaid, and 10% by other third-party payers, and I can tell you that's a terrible payer mix. You do not want to have more than 50% Medicare and more than about 30 or 40% Medicaid, and you want to keep the Medicare and Medicaid together down to below 70% when you add them together, not 90%, but 70%. Otherwise, you will not make any kind of profit or even break even on your payer mix. So, okay, enough of my commentary. Getting back here, the example is that the 70, 20, and 10 is their payer mix at this ratio. And financial stability, you have fixed costs, you have variable costs. Fixed costs, there's not much you can do about those. Variable costs, you have to just adjust and try and manage those as best you can. So when you have lots of patients and you have lots of healthcare workers, that's one thing. But when your volume of home healthcare visits is low, you need to handle your labor costs and handle other things appropriately. And then there's Medicare coverage issues that can pop up now and again. And so the home health agency is reimbursed for nursing and other patient care through Part A, but durable medical equipment is covered under Part B. And there are things that are not covered. So you just have to be aware of what's covered, what's not, because that can affect the financial stability of the agency. And then audits, we've talked about how important audits are. Definitely they have to submit cost reports, so you need to make sure that your record keeping is meticulous. You need to handle denials, claim denials. What do you do if Medicare won't pay? Does the patient have secondary insurance, or are you going to have to bill the patient? How are you going to follow up on that? Is there something wrong with the claim itself that you need to resubmit it or do something different? So there's all those types of questions that come into play when you're talking financials for home health care agencies. What about coding? Yes, you have ICD-10-CM for all diagnoses. Yes, yes, yes. But if you're doing any types of procedures, again, you're using CPT. And there's a whole section in your book on this that I will refer you to starting on page 463, going to 464. They give you an excerpt from the OASIS guidance manual. Now, granted, this is back in the day of ICD-9, so it's fairly out of date, but it still gives you the idea, and that's what you really want. And then you've got CPT, and all of this extends to page 467 in your book. And we covered CPT, that's in your book. So what are some other things? You definitely have data and information flow. You're moving information back and forth to the healthcare provider that ordered the home healthcare services and staying in touch with them. Occasionally, home healthcare agencies will have to contact EMS to have them come out and take a patient into the hospital for care. So there's some data information flow there. You have it when it comes to claims and coding and billing and all of that. And then there are some that are part of health information exchanges and things like that. And yes, again, most home health agencies that are owned by major healthcare organizations are electronic these days. But many others that are small, tiny, independent, they may still be doing paper or some kind of hybrid system. So you just need to be aware. And then, of course, their major data set for the home health care field is OASIS. What about quality improvement? This is on page 468 in your book. Well, there's a lot of information in OASIS, and that's used to measure quality performance. Ways you can look at for quality improvement, you can go to the state and look at reports. You have to submit reports to the state on a regular basis, so there's all of that. There is some benchmarking in the home health field. The home health provider selects outcomes for enhancement, evaluates care, develops a plan of action to change the care, monitors to see if desired gains are accomplished. And also, there are best practices in home health. There are evidence-based care plans for home health. It just depends on the focus of quality improvement by that specific agency. So here's the two-stage OBQI framework that they talk about in your book, specifically when it talks about CMS. So you collect your OASIS data here. Where's my mouse? My mouse alive? Okay, mouse is alive. Outcome analysis. So you collect your OASIS data, you process, edit, and transmit it. It produces risk-adjusted outcome reports. You can then look at that report and decide, okay, here are the target outcomes that I think we should enhance or could enhance. Then you evaluate the care for those target outcomes, develop a plan of action to change the care, and then it starts all over again. And the information from that next round will help you know, did it really do anything to help? Did it improve anything? And you just keep going with that. Utilization management, that is where you're looking to see, are the services the most effective and efficient for the patient and their condition? Does it make sense? Are we over-treating the patient? Are we under-treating the patient? Or are we giving them exactly what they need? It should be a written plan. I think in some places it's required to be a written plan for utilization management, many places. They're looking at how they improve processes that affect customer base and are competitive in pricing quality. And then that involves HIM typically because we're big into data analysis. And so we can sometimes get pulled into that aspect of things. Risk management and legal issues, there always are some. Doesn't matter what setting you're talking about. Absolutely, there's incident reporting. Patient or consumer satisfaction monitoring absolutely is required. You need background checks for all employees. OSHA, good old OSHA, making sure it's a safe environment for your employees, that they are safe. One of the biggest safety challenges for home healthcare agencies is that you are sending nurses and other staff to patient homes, and sometimes those homes are not in safe neighborhoods. How do you handle that? There have been times where home health nurses, I've talked to them specifically, have shared with me that they felt uncomfortable about going to a patient's home, that they actually drove up to the home, they noticed suspicious activity in that neighborhood within eyesight, and so they decided to drive away and try and come back later. Making sure that they do their visits within daytime hours. Making sure sometimes that you send 2 employees instead of 1, where 1 might be more vulnerable, whereas 2 might be a little more protected. Making sure that they know to call the police if there's any kind of issue. There's all sorts of safety things when it comes to home health that are different than some of the other places. So just keep that in mind. I mean, another example can be, I think of Chicago and all the horrific violence in some of the suburbs of Chicago. And if a home health agency nurse needs to get to a patient in one of those neighborhoods, how do you make sure it's safe for them? So from a risk perspective, employee safety is just as critical as patient safety, and you have to think outside of the box, because these are patients you can't bring into your facility and care for. These are patients you have to go to their homes. What happens if the home itself is not safe to get into? You know, again, you've got to have a plan to deal with this and be able to train your employees so that they know, okay, here's what you do. Confidentiality is absolutely critical, no matter what part of healthcare you're in, and making sure you have written policies and procedures and everyone knows what they are, and they're updated on a regular, at least annual basis. They're reviewed. So it's all of those things. All right, so what does HIM have to do with home health? Well, a lot of different things. Sometimes it's finance, sometimes it's quality, sometimes it's utilization review, sometimes it's IT, sometimes it's managing the documentation, sometimes it's accreditation readiness, sometimes it's making sure that the information is ready, available, and uploaded correctly and appropriately and timely. Because home care is now becoming more and more data driven. And then we can also have a role in developing, implementing, and maintaining effective information systems. So there's plenty to do. We don't often get called in, but we definitely have skill sets that would be very beneficial to home health agencies. And as I've said in my HIM career, I have been involved in all of those different aspects. So some trends, what's going on with home health? Well, looking at home-based primary care and disease management. How are we able to utilize home health care to keep congestive heart failure patients in their homes instead of back in the hospital for readmissions? There's all sorts of programs that you can set up through home health to help patients with congestive heart failure or COPD to manage their disease and do it so that they don't end up back in the ED or back in the hospital. For instance, I was involved in one program where we provided patients that were in our CHF patient group as they were being discharged from the hospital. It was a voluntary thing if they were a CHF patient and they wanted to be, and they wanted to be part of this, and their doctor certified that they needed home health care, they could be. And we provided them with a scale. They had to weigh in daily, and the information from their scale was sent wirelessly back to the home health agency to be monitored. The home health nurse would make a phone call every day checking on them, because you can tell from their weight if they're gaining fluid. And the nurse would talk to them about their diet, what had they been eating, and once a week we'd have a dietitian call them. But the nurse would check in with them to see how they were doing, how they were breathing, to work with them, to take their pulse, to work with them, you know, just on things. Were you taking your oxygen as you needed to, and just being that questioning sounding board of reaching out, saying, I'm here for you if you have questions. I'm here to make sure you're taking your medicine appropriately at the right times. You know, did you get back on your Lasix? Are you taking your Lasix? Are you having any issues urinating and things like that? And a lot of those patients, it was amazing to see how many of those patients they were able to keep out of the hospital or out of the ED, and for how long, and how many relationships that built with the home health staff, and how those patients really became close to them, and they felt like they had a healthcare advocate that they could ask questions to, and that would tease them and support them and encourage them through their disease management. So that is very possible. Telemedicine, absolutely, that can happen, so that you could have telemedicine visits with your primary care physician now through home health in the home. Or if a home health care nurse is in the home caring for a patient and they notice that their wound is worsening instead of improving, they can do a telehealth visit with the physician that ordered the home care to look at the wound, so they can show them the wound and talk about through their concerns and identify next steps for the patient. Maybe they decide that they're going to do some type of additional wound care, and the doctor will then order that, and the nurse can carry that out. There are possible changes for payment systems coming for post-acute providers. This is 2018, and that, of course, continues to roll out. the slides are 2018 and we're now in 2020, so we've seen that post-acute care provider payment system changes continue to roll out, is what I meant to say. Sorry about that. All right, and then Independence at Home program, really trying to help patients be as independent as possible at home, helping them find ways that they can take better care of themselves and utilize less services, but all in a safe way. So I'm sorry, going back to this, some of the things that they can do is come in and do an assessment where they recommend that you not have rugs on the floor, that they address that they have some kind of socks on at all times that have grippers on the bottom so that they don't slip and fall. Identify different furniture placement, especially if someone's using a walker, to prevent accidents and injuries. Talk with the family about setting up their pill box. There's all these different things that they can do to try and establish increased independence for people at home. So, summary: home health is quality care at a reasonable cost. Changing regulations require creative business planning. Yes, they do, and you have to watch that case mix that you have. HIM professionals can contribute with clinical and technical aspects of information management. Absolutely. Among other things. It's not just information management. There's so many other things that we can be of benefit to home health agencies for. So some web activities if you're interested. And again, take a look in your book and do some self-review questions. Do the review questions. Let's see here. In the back of your book, you have a glossary. So don't forget, if you're not sure about the definition of something, look it up in the glossary. That starts on page 632. So all sorts of good things. Take care. Have a great week. And, oh, yes, I will be back to talk to you shortly on Chapter 13 on hospice because we're doing both this week. So I'll be back soon. Bye.